mendelspod.com, advancing life science research, connecting people and ideas.
Welcome to the program. We're in San Carlos, California at the office of Bonnie Addario. She's the CEO and founder of the Bonnie Addario Lung Cancer Foundation. This is a foundation that's patient-centric, that's focused on raising awareness and funding research in lung cancer. For more than a decade, Competitive Group has helped science-based companies build and execute innovative marketing campaigns. They love science, they love marketing, they love the idea of combining the two to make great things happen for your marketing communications. Welcome to Mendelspod.
Thank you.
So I want to get into what you're doing with the foundation. There's various patient foundations sprouting up, becoming a major part of biomedicine. But first of all, you have a powerful patient story yourself. What happened?
Well, right now I'm a 9-year lung cancer survivor. But 9 years ago, that wasn't the case, and I had chest pain. And I went to my general practitioner and told him about the chest pain. And I'm not the kind of person that goes to the doctor easy. I went one time with pneumonia to immediate care on my way home from work. But this just didn't seem right, so I went and told him about it, and he gave me a chest x-ray. Didn't say anything. Sent me to a heart doctor, a heart specialist. They took a bunch of tests. They didn't see anything either. Finally said, you know what? We just don't see anything wrong with you. But I still had this chest pain. So
one of these diagnostic odysseys.
Exactly, really an odyssey. So I went and paid $1,600 for a full body scan in San Jose.
Independent from your doctor?
Independent from my doctor. I just knew there was something wrong with me, and I saw these scans advertised in the newspaper, and I thought, well, let me go just see what happens. I took the scan. They told me 5 minutes after I was finished with the scan, they showed me the tumor on my lung, and they said, you need to get to a doctor ASAP. The tumor I had was actually on my aorta, and the reason they didn't see it on the original x-ray was because it was behind my heart, on the aorta and the subclavian artery. And it was squeezing the aorta, and that's what was causing the pain. So one thing led to another, and they felt like they needed for me to have another CT scan just to confirm what the first one said. So went along with that, we did that. Finally got confirmation. They tried to do a biopsy for pathology to see what kind of chemo or whatever to put me on and to confirm that it was cancer. They did that, couldn't get a successful biopsy because it was so close to my heart. They just were afraid to get in any deeper. So they suggested exploratory surgery, which didn't really sit well with me. But luckily the surgeon that they wanted me to see was on vacation. So I came home from work one night and I saw this little article in the San Mateo Times. It was no bigger than this, about this professor of thoracic surgery from UCSF that comes down to Sequoia Hospital once every Tuesday and performs lung cancer surgery. So I thought, oh, I need to see him. And coincidence of coincidence, I was on the board of Sequoia Hospital. So I made some calls. I was in seeing the pulmonologist the next day. She took my scan several places, one of which said she's inoperable. There's nothing we can do, maybe a little chemo, maybe a little radiation, and that'll be it. So she took it up to UCSF, met with David Javelins. He met with an oncologist and a tumor board up there and at Sequoia. They all agreed that he would do surgery, although he said it would really be a challenge and couldn't even guarantee that I'd get off the table. But he said, what I can tell you is if you don't do this, you won't be here in 3 weeks. That tumor is going to crush your aorta. So I said, let's go, let's go. So they put me on some major carboplatin Taxol chemotherapy to see if they could shrink the tumor. Radiation every day, Monday through Friday, for almost 3 months. Chemo every Friday. My hair fell out in 10 days. None of which bothered me because I was just never, ever going to die of lung cancer. It just didn't compute. So I ended up having a major surgery at UCSF about 3.5 months later. On St. Patrick's Day, I knew that was a good omen. And they removed my top left lobe, part of my esophagus. They had to wrap the two arteries where the tumor was invading, and paralyzed one vocal cord. But had a few things later, side effects and what have you, but I'm here today. My surgeon asked me to be on his thoracic oncology board. And I was thrilled to do that. Learned a lot about lung cancer. Just went everywhere on the internet I could go to find out more about lung cancer. That's just the kind of person I am. I just needed to do more. And I wanted to do more because the one thing I learned early on was that the survival rate was only 15%. And it had stayed 15% for 45 years. In this country and Europe and Asia, in the world, we've lost over 50 million people in 45 years to this disease. And
it's the leading killer among cancers?
It's the biggest cancer. It's the leading killer of both men and women. And I wanted to know why. I couldn't accept a survival rate of 15%, especially when you're seeing breast cancer survival rate up in the 90 percentile, colon cancer in the 80 percentile, prostate cancer 99%. I wanted to know why and learned that it really was nothing more than a stigma, and that people felt that people that had lung cancer brought it on themselves and that they shouldn't spend a whole lot of money changing that. Well, that's not true. That's totally not true.
It's not just smoking related.
No, smoking can be a cause or a trigger of all cancers. It certainly causes heart disease, vascular disease, many other diseases. So I set out to change that, and I left the oncology board up at UCSF and started my own foundation, determined to make change. Wasn't as easy as I thought it was going to be, one step at a time. And
but that is unusual that you decided to just go out there and make it better for others.
Yes.
So
yeah.
What led to that passion?
The injustice. Robert Kennedy, I don't know if you ever heard this quote, but long ago when Cesar Chavez was working for the immigrant farmers and the injustice that was happening to them, Robert Kennedy was describing him, and he said, if you're passionate about an injustice, do something about it. And I was very passionate about the injustice in lung cancer. And that 50 million people, that's an epidemic. That's just beyond what people, even today, I've been at this 9 years and still people don't know how huge this disease is and how many people that it's affecting.
So what was your thoughts with the foundation and what you could do?
Trial and error. The first year was really trial and error. We did a lot about CT screening because, I got my own screening, and I thought this should be available for all patients that, have lung cancer in their families or, are symptomatic or what have you, and they're not being successful with their doctors. So we did a whole campaign on CT scanning awareness, making people aware of this disease. We actually had, posters in the subways in New York, posters on buses across the United States, just bringing attention to it.
To build awareness.
To build awareness, and we really got quite a bit of attention, but still, it wasn't really making a difference. So one thing led to another, and along the way, we had a gala in San Francisco, and we decided, well, we're going to do this. We're going to raise money. My original thought was I'd give it all to UCSF because the doctor there was the person really who saved my life. So we had a gala. We had it at City Hall. We lit City Hall up in pink and green. We had 700 people. We invited Claudia Henschke, who was the founder, actually, of CT screening for lung cancer long ago from Weill Cornell. She came to speak. Chuck Hagel came to speak, and who is now our Secretary of Defense. His mom died of lung cancer, and at that time he was a senator for Nebraska. And we had an amazing evening, and we raised $800,000 just from sheer will and persistence and you know, not being afraid to ask. I didn't know Chuck Hagel in any way, shape, or form. We've had Dianne Feinstein speak. We've had some amazing people. This last year at our gala, we had the West Coast president of Pfizer there. But the year before, we reached out to a doctor. His name is Hiro Mano. He discovered the ALK gene, which Pfizer has a drug called crizotinib for. So the year before we had Hiro Mano, we flew him in all the way from Japan. Our audience was just mesmerized at what this man did. He's humble and just amazing. So we brought the entity that created a drug for that marker, for the ALK biomarker. So we do things very differently, not afraid to ask. You know, people can't say no unless you ask them, but they also can't say yes unless you ask them. But in 2008, we were rolling along and really raising awareness, but not really, that survival rate wasn't changing. And that's my goal. That's my barometer. It's
that's
my
your
personal
number.
barometer. That's my number. So we decided we needed to have a summit. We invited lung cancer leaders from all over the world to Mission Bay up in San Francisco, asked Mike Milken to come in and do the keynote speech, which he lovingly agreed to do. But again, people said, oh, you'll never get Mike Milken to come. Well, he came. And he did the keynote speech. He spoke for about 90 minutes. And then we had a summit for a day and a half. I told people, don't bring your PowerPoint presentations. We don't want to see what you're doing in your clinics, and we don't want to see what you're doing in your labs. We have one question to ask you. If money were no object, what's the one single thing you would do to change the survival rate for lung cancer? So you can imagine, you know, the first 4 hours was, you know, we were getting nowhere. You know, we were getting nowhere because they couldn't.
They were still in the old frame of mind.
Still in the old frame of mind, and they couldn't step out and, you know, dream, you know. Remember, money
Thinking
is
how
no
they would
object.
apply for an NIH
right.
grant still.
Exactly.
How they
money
could
is
fit it
no
in.
object. So on the second day, about 2 hours into it, and we had our gala that night. So we had the summit Saturday and Sunday. Our gala, they all came to our gala that night. We had the final end of the summit the following day. Harvey passed, thoracic surgeon from NYU. He stood up, and his hands were moving, and he said, this is what we need. We need a virtual biorepository run by an honest broker that will collect data from a collaborative group, contractual collaborative group that all agree to share, and will have a database that's open to everybody that wants to see it.
And what kinds of data, for instance?
Well, data on what they're doing in their own research labs, what they're failing at, as well as what they're succeeding at. Because currently the way research, you can have multiple hospitals or multiple institutions working on the exact same research. But if they share what's not working with everyone, then you can skip right up to the next phase and waste a lot less money.
This is part of this movement for open science and collaboration, because there's so many silos within research.
Exactly.
And the incentives, right, the researchers has to make their
Is
name.
to publish.
And it's to publish. Exactly.
So, you know, all of that information really isn't truly shared until they're published in the New England Journal of Medicine or Nature or whatever.
And then they don't publish the negative results.
Exactly. You know, so our goal is, so we did it. In 3 days we had a name. It was called Alchemy. And what inspired
in 3
us.
days.
Right.
So he got up and talked, you listened.
Right. 3 days we had a name and we called it Alchemy. And we were inspired by alchemy, ALCHEMY, which is the search for a cure. So we took our name and medical institute, ALCMI, Addario Lung Cancer Medical Institute, also Alchemy. So it's Alchemy and then Alchemy in italics below it. And we created this, but the brilliant part of it is we have an amazing business in Southern California called Response Genetics. They're storing our tissue for us and blood. They're also doing the genetic testing on these tumor tissues and blood that we're getting from patients from our collaborative consortium, which includes Vanderbilt and UCSF and USC and Italy, Spain, and we just signed on France. So this is all happening in real time. We're storing the tissue. Response Genetics is doing it at no cost to us. A company in Colorado called Biodesics is storing plasma and blood at no cost to us. And they also are sharing the data that they get back on the molecular testing. All because this is the right thing for the patient.
What's the most important thing you've learned about lung cancer since you had your own surgery?
That anyone can get it.
That anyone can get it?
Anyone can get lung cancer.
Old people, young people?
All people, young people. There's no early detection for it. And, you know, awareness is key. Awareness is key. But we have a long way to go because the survival rate after all of this, 8 years of all this hard work, the survival rate is still just a couple ticks up, like 15.7%. It's not changing fast enough, but we're at the cusp. You know, all of this work we've done in the last 8 years, and the people we collaborate with, and the life sciences groups, and, you know, most people now recognize that the solution is in our bodies. When I say our bodies, I mean a patient. They all talk about translational medicine from the bench to the patient, but I say, no, it's transformational medicine. It's from the patient to the bench and then back to the patient with a drug. You take our tissues, you take our specimens, sometimes multiple biopsies, clinical trials, all the things we offer up. I just recently spoke at a pharma and I gave them a shout out. I said, you know, you have a drug right now that is on the table for FDA approval. And I hope that when that drug is approved and you're on the front page of the Wall Street Journal, that you give a big shout out to all of the patients that offered up their tumor tissues and their blood and their plasma and infusions and clinical trials to get you where you need to be. Because without patients, you'll never have drugs. It just won't happen. You know, to get back to the discussion we were having about anyone can get lung cancer. You know, we really believe that there is a lung cancer that's inherited and, you know, is carried through the genes. And we're driving a research study this year on the T790 marker that we're really very excited about. And the other one is young lung cancer. No one knows what this is about. But all of a sudden, very young people are getting lung cancer. They're never smokers. We had a young girl, her name was Jill Costello. She was the coxswain of the Cal Berkeley crew team. She was diagnosed with lung cancer at age 21 and she died at 22. Her cancer went fast. She didn't have any of the known biomarkers at the time. We have another little girl here today working in San Francisco as a intern chef, learning how to cook. She's traveled all the way from Weill Cornell, from New York, where she's studying. And she said nothing is going to stop her. She has stage 4 lung cancer. We've arranged for her to have her chemotherapy at Stanford while she's here. She's absolutely adorable, a go-getter, but she has stage 4 lung cancer. She has a very serious disease. And that goes in line with what I said earlier. Anyone can get lung cancer. Doctors can get lung cancer. I don't know if you can see over here this gentleman to the left or to my right. He was my oncologist, and he was actually diagnosed with lung cancer 2 years after I was. And he's not with us today. He didn't make the cut. But I remember when he was diagnosed and he actually had to have surgery too, and he said, Bonnie, I'm so sorry. He said, I had no idea. I just had no idea. I'm so sorry. And he was a great doctor. He did the very best for me, but he still never really understood until he had it himself. Anyone can get lung cancer. And regardless of stigmas and what we perceive as something self-inflicted, you know, people cross the street every day in traffic, they jaywalk, they make poor decisions every day. They jump out of airplanes, they bungee cord jump, they do all kinds of things. No one deserves to die. We, as a country, we talk all the time about what a wonderful country we are and how we protect our people. Let's protect all of them, even the ones with lung cancer.
I'm very intrigued that you were a businesswoman. I mean,
Yeah.
you mentioned during your story how you come home from work and then doing this.
Right.
And so you've come really as an outsider into this world of biomedicine
Right.
and said, what can we do different? And I'm curious, what did you see that you said, oh, we can do different there?
You know, I think the first thing I saw was bureaucracy. I saw this huge bureaucracy that really weren't sharing amongst each other.
Bureaucracy in healthcare system?
Healthcare
bureaucracy
system.
in research, academia? All of it.
All of it. Everywhere. Broken. Broken, broken, broken.
And that's one thing the Patient Foundation can do. It
Right.
sort of is this common place
Right.
that they can all come into and out of.
Exactly. Exactly. Starts here and ends here. We have so much to offer, and, you know, our patients are smart people. They're not stupid. If you tell them how to get the right care, they will go and get it. You know, the days are ending where a patient goes to see one doctor and believes everything they say. You know, I was one of them. I almost did it. I almost went in and had exploratory surgery. And it's like, oh my God.
But you're really an example of this empowered patient.
Right.
It's interesting you say 9 years ago, because you mentioned the internet a couple times.
Right.
The internet's had a lot to do with this.
The internet's
But you're a
had-
big believer in this empowered patient
Yeah.
that Eric Topol talks about.
Yeah.
That takes
And
charge of their own health.
in very many ways, we tell patients to stay off the internet. Because once information gets on the internet, it doesn't come off the internet. And when I started looking about lung cancer 9 years ago, I was a dead person. You know, it just said, well, stage 3B, 2% people survive. Out of 1.4 million worldwide, 2%, that's not a lot of people. So I was terrified. It's like, well, why would I even have surgery? Why am I even going to try to fight this? It's not going to be a success. So now there's good information on the internet, but we've decided we're going to be the entity that collates this for patients and makes it understandable to them, makes it easy for them to understand what the steps are to get the right care. And we have to do that with the doctors as well, and the physicians that are actually out there working. 80% of all cancer patients today are seen in community hospital environments. And there is no standard of care in that arena for lung cancer. There's no standard of care. You know, some people believe that they should give you molecular testing, if at all. They believe, well, maybe we'll give it second line or third line. I liken molecular testing and genomics as a carpenter. He gets up in the morning and he's going to go out and build a house. He picks up his toolbox, and in that toolbox he's got a hammer and a screwdriver and a saw and all the things he needs to build a house, right? If he leaves his hammer home, he's in trouble. These doctors have to do the same
Molecular
thing.
testing is a
Molecular
major
testing.
tool.
Major tool.
And you're
Major
you're
tool.
discovering new biomarkers that
Exactly.
you're working with.
Exactly.
This T790.
Exactly. Exactly. And you know, it's just you shouldn't be treating a lung cancer patient without having all the tools and taking all the tests that you possibly can test. Because we know, for instance, what doesn't work by giving a molecular test. You might have a patient that he or she are not going to qualify for a targeted drug that can be taken orally. But we also know that a very toxic infused drug isn't going to work on them either. So the days need to be over where we're throwing spaghetti at the wall and waiting to see what sticks. We need to be informed. Physicians need to be informed. Our goal, rather than try to change the bureaucracy out there in the medical world that really truly is broken, we're going to empower and educate patients to know what to ask for when they walk through the doors, and
Okay.
not stay there unless they get what they need to survive.
So rather than focusing on the people in the top of the organization,
Right.
you're going right to patients.
Exactly.
They can tell their doctors. They'll do a lot more
Exactly.
work.
Exactly. Exactly. And it's working. It is working.
So our audience is all life sciences. What's your message to people in our audience, the researchers, the people at pharma?
My message is simple. Involve patients in your processes. We are not only part of the solution. We are the solution. Patients are the final tool in your box. We are the key to your success.
What are some of the things ways that they could have patients more involved? I mean, we know that sort of the FDA has their patient, panels whenever they introduce a drug.
Right.
How could pharma collaborate more with patients?
It's very simple to me. You've been to Nordstrom's?
Yeah.
Shop there?
Mm.
Why?
Nice stuff, I guess.
You're valued.
Oh, okay.
You're valued.
I feel good in there.
Customer walks in Nordstrom's, you are valued. And if you bring something back because it doesn't fit or you change your mind and don't like the color, they don't treat you like the enemy. They just say, well, of course, Sarah, bring it over here. We'll take it back. And is there something else you'd like to select, or would you like me to charge your account?
It's been a while since I've been in Nordstrom.
Okay. But they value you. Life science, pharma need to value the patient. Less than 4% of patients participate in clinical trials. Imagine what we could do if we could get that number up to 50%. Imagine. But they have to completely revamp the way they do clinical trials, and they have
and go more for the targeted trials?
Well, they just have to make it easier on the patient. Very rarely is the patient actually in mind when they're creating a clinical trial. I'm on the SWOG group, the Southwest Oncology group, and I'm the patient advocate there for lung cancer. And I was just at a meeting in San Francisco about a month ago, and they were talking about a particular clinical trial, and they were saying, well, this one we'd get the patient to come in 3 times a week, and we would do this, and this. And I said, excuse me, aside from the patient being very sick, most of your patients work. They can't come here 3 times a week. You have to create your outcomes, and then you have to customize your clinical trials to be patient friendly, easy for the patients. Maybe get pharma to start funding some of these patients that have to travel hundreds of miles to get to clinical trials. Leave it to us to teach the patients that clinical trials are a good thing. There are targeted drugs that are being used now worldwide that were in clinical trials 5 years ago. Good things happen at clinical trials. But there's a concept out there that people are guinea pigs, and they're just, they're not valued. They don't feel valued.
These patient foundations have become a major part of this industry.
Yes.
You're funding research, you're bringing the patients closer to the researchers. How has the patient foundation evolved over the last 5 years?
We're not only funding research, we do fund research, but we're very focused on, we only fund research that has the potential to have an immediate impact on patients. But we're driving research. We actually have 3 research trials of our own, 2 that have been launched and 1 that's going to be launched in another couple of months. We're driving the payers to pay. We have to bring this whole thing together. You can have the best of drugs and the best biomarkers and all the most wonderful things going on, and if Medicare is not going to pay for it, it's not going to help the patient. So we participate in this process at every step of the way. Every step of the way. When we're in a meeting...
And that's unique.
Yeah. When we're in a meeting and we're talking about maybe doing a new trial or a new project or what have you, and some people are in agreement and some people are not, the tiebreaker is always, is this good for the patient? If the answer is yes, we're going to do it. Even if it's only good for a few of them, we're going to do it. We're not focused all the time on just doing things that are good for the masses.
Bonnie Addario.
Yes, sir.
She's the founder of the Bonnie Addario Lung Cancer Foundation. Thank you very much for your time.
Thank you, Farrell.
For more than a decade, Competitive Group has helped science-based companies build and execute innovative marketing campaigns. They love science, they love marketing, they love the idea of combining the two to make great things happen for your marketing communications.
You know that story about the man walking down the beach and he's picking up starfish and throwing them in the water, and he keeps going and picking up starfish and throwing them in the water, and somebody was behind him watching, and she said, "You know, you can't save them all." He said, "I know that, but it sure means a lot to the ones that I did." You know, so